Okay, I'm going to go on ahead and get started. We do have a wonderful event to kick off today. We had a great showing last night with a wonderful happy hour, and thank you for everybody who joined us yesterday. Next, I would like to thank our sponsors. Our sponsors are what makes this event happen and what allows ESPN to really make an impact in the educational elements as far as benefits are concerned. If you're interested in sponsorship, just give one of us a call and we would be glad to assist you with this. And then I would like to thank our event sponsors. These sponsors not only helped make the event possible, so thank you to our event sponsors today. We also have even more upcoming events for even more education. Tomorrow's session will also start at 10 a.m. Please join us. We have pharmacy topics and a great pension and retirement session tomorrow. So I hope you will join us. And then on October 8th, we are hosting the Secret Sauce to Fixing Healthcare. That will be a live webinar that will be interactive, and we would like for all of you guys to join us for that. And so with that, I have the pleasure of introducing Scott. Scott is the Director of Data Analytics. He is definitely a data geek. So if you like numbers, this gentleman is definitely somebody to know. One of the things that I like about this is he actually uses data to drive more favorable outcomes for you. So if you're looking for that value-based program and you want to make sure that it's going to be successful, he uses data to drive these initiatives. And he shared with me some really special information. And as I'm a weather geek or a weather weenie, as I just learned, he was also a meteorologist. So prior to his life in the data analytics and healthcare industry, he was a weather meteorologist, and I found that extremely interesting. Today's Unlock Impactful Communications with Data will be a wonderful presentation, and so with that, I turn it over to Scott. Please also, really quick, there's a chat button and a Q&A button down here. Please feel free to use those if you have questions. And if you have any additional challenges or issues, you can definitely let us know through those areas as well. So with that, Scott, I will.
Thank you, Michelle, and good morning to everyone. Thank you so much for joining us this morning for this presentation, Unlock Impactful Communications with Data. And I have to re-stress what Michelle said. If you have questions, even comments, please feel free to share them in the chat window. It is very difficult, I think we all can agree, in the current climate, doing these events virtually, not getting to actually sit with each other and look each other in the eyes most of the time and have back and forth conversation. But I do want this to be as interactive as possible under the circumstances. So please feel free, and I strongly encourage you to ask questions and make comments. We'll pause at points throughout this entire PowerPoint to share those and hopefully provide some more insight that's meaningful to you. I don't want to sit here and lecture to you. I want this to be meaningful to all of you. So please, I welcome that feedback, and I hope that you will be willing to participate by providing that feedback as we go through this conversation. So all that being said, we're talking about impactful communication. What is impactful communication? I hate to use the words to define the term itself, but it really is just that. It's communication that has an impact. It's ways that you can work with your population. And the crux of the conversation today is really going to be around your benefits program. We tend to focus primarily on the medical and prescription programs especially. But what we're really going to talk about today is how can we use data to make our communication strategies much more impactful? How can we get people to engage in the types of behaviors that we want them to engage in using data to drive that communication strategy? And I will preface this entire presentation with the following, which is anytime that I make a presentation, anytime I sit down with a client, anytime we make any sort of data-driven recommendations, we always have three goals in mind. When we talked about, I mentioned how do we get people to do what we want them to do? The goals are three. How do we save you as the employer and plan sponsor money? How do we save your employees and their family members money? and how do we get better outcomes. If we're not accomplishing all three, we don't want to give it any real credence because we really need to accomplish all three. We don't want to just shift cost and shift risk onto your employees and their family members. We want to get that better outcome, and we want to save them money as well. We want everyone to win using data to drive these types of strategies. And communication is key. And so when we're talking about communication, there's a few things that we really do have to consider for this communications strategy to be impactful. First of all, we have to think about why are we communicating to the members? We have to think about how should we be communicating to the members? We should be thinking about whom are we actually wanting to communicate with? When do we want to make that communication? And what message do we want to communicate? Many times what I see when I'm working with organizations is organizations view their employee population as a singular entity. It's one large entity. And communications are very, very much straightforward in terms of it's a uniform message. It's the same message to every single person, and it's all sent at the same time, and it all contains the same content. And in a data-driven world, we can do better than that. Because what we'll notice is that when we do these massive communications and everyone gets the same thing at the same time in the same format to the same people, the impacts are very low and we don't necessarily see that strategy driving behavior. And what we're going to talk about today is how we can be much more strategic and get much better outcomes when we think about these areas in terms of how to communicate with our employee population. Let's start with the why. So why do we want to communicate with our members? There's a lot of reasons we want to communicate with our members. This was a study we did a few years ago, and I found the results very, very interesting. We took employer plans that were all basically, from an actuarial standpoint, the same in terms of benefits. So imagine, if you will, we go to 100 employers that all offer a $2,000 deductible HSA that's 90% coinsurance. They're all the same exact plan from a medical plan standpoint, right? And we also looked at their communication strategies, basically graded them in terms of whether or not we consider them to be effective or not effective. And we did this all up front, so there was no analysis on the back end. We were trying to make this as scientific as possible. And we had them all do employee surveys in terms of how they viewed the plans themselves, what type of value they applied to the plans. And with these identical populations in terms of identical plans from an actuarial standpoint, the populations that we flagged as having an effective communication strategy, you can see 86% of their employees viewed their plan with a high value perception. The populations that we classified as not having effective communication strategies, only 74% viewed it with a negative value perception. Only 26% rather had a high value perception of what amounted to the same exact plans. So you can see how effective communication in and of itself will enhance the value proposition and the perceived value that your employees have within their plans. That's just one reason why we want to have a communication strategy. Obviously, we want our employees to have a positive perception of the plan. We're going to take it a step further, because what we're also going to talk about is how an effective communication strategy can achieve those three goals we discussed before. We can get better outcomes for members, we can save the plan money, and we can save the member money as well. So that's a secondary reason why we want to communicate. I think we can all agree open lines of communication in every aspect of life is certainly a positive, and being effective at that, being a good communicator, is obviously a skill, but it's a skill that can be learned. It's very much a skill that can be learned. In today's day and age, obviously, we have a ton of ways that we can communicate with populations, specifically in this instance, our employee and their family member populations. So we have a whole list. I'm not going to read through all of them. Not included in here, though, is actually virtual meetings and Zoom and things like that, but I'm sure we can add that to the list as well. So you have all of these options and opportunities into how to communicate with your members. And I would be shocked, but I mean, it's certainly possible, but I'd be shocked if you're sitting here looking at this, if you said we communicate effectively with our members through all of these platforms, and we're strategic about how we communicate with our employees, utilizing all of these platforms in a cohesive strategy. I'm sure many of you utilize all or most of these platforms in some way, shape, or form. The question is, are we maximizing the efficacy of each of these platforms? Are we using them to their full potential? Are we using them, again, going back to those original questions, right? With all those different ways to communicate. Are we thinking about, with all those platforms, when to communicate, who we want to communicate with, what we want to communicate, and why we're communicating with these people? So every single time we look at one of those buckets, we have to think about all those other questions and make sure that we're doing things correctly. So let's consider, first of all, how we want to communicate with our members. there's no rule that says we have to communicate with all of our employees in the same exact way, right? Millennials in general, and I'm going to make some generalizations here, don't get upset. In general, millennials like to receive communications in more what we'll call technologically advanced ways, right? Millennials like getting text messages. They certainly work through email. Generation X definitely prefers email in general as a way of communication. Baby boomers would rather get a phone call or face-to-face conversation, and they still tend to look at their mail a lot more closely, where if you send a letter, a snail mail letter to a millennial, in general, that's not something that's necessarily going to be viewed as favorably and received as well. So considering just the different generations and the different populations you have in your population. Personality profiles, that's kind of a vague statement, right? Different types of personalities like to receive communications in different ways. Very, very basic example would be just think about an introvert versus an extrovert, right? An introverted person may not necessarily feel comfortable sitting down in your office as a manager and having face-to-face conversations. That may not be the most comfortable way for them to communicate. Now, sometimes that's obviously necessary, but it may not be a way that they prefer to communicate, where they might prefer other more, let's say, indirect ways to communicate. I'm going to talk a little bit more about these personality profiles. Also, we want to consider group versus individual communications. Again, a lot of times in benefits, we see communications strictly geared at communicating with the entire population. Hey, everyone, here's your benefits. Here's our required notices, your COBRA rights notification, your Medicare rights notifications, and so on and so forth. And we tend to blast out these communications at a group level. But at some point, if we want to be more strategic and we want to maximize the way that data can help us drive better outcomes, we have to start focusing on individuals and also pockets of individuals within a population, and how we communicate to those pockets of individuals. So I'm kind of laying the groundwork here. I know I'm being vague. That is by design. We're going to get into some specific examples coming up. So if this all seems kind of like fluff, like so what, now what, don't worry, we are going to get into some specific examples in terms of how we're going to actually apply all of these different thought processes to a communication strategies. So fear not, we will definitely be getting there. So personality profile. I'm a fan, just personally, there's no right or wrong personality profile, but I do like the DISC profile as an example. I'm not sure if any of you are familiar or utilize the DISC profiles in your own professional lives, but it's a great way to measure certain aspects of individuals and their personalities. So DISC, for those who don't know, stands for dominance, influence, steadiness, and compliance. And basically a DISC profile is a survey of 20, 30, 40 questions an individual will answer, and it will place weights on these 4 factors and how they impact an individual's personality. And there's some very, very different results that you can find from different types of individuals. So I'm going to share my profile with you right now because basically what my profile is, I'm a results-oriented individual, which basically means I'm a jerk, quite frankly. I am apparently an egotistical. I'm very individualistic. I like to be dominant and independent. But within this profile, there's certainly very important hints in terms of ways that you might want to communicate with me. So results-oriented individuals, for example, don't necessarily need you to take their feelings into account. They much prefer direct communication, get to the point, don't waste my time, don't worry about my feelings, tell me what you need to tell me. Someone who has much higher, for example, steadiness and compliance, for example, they are much more emotional. So for someone at high S, for example, you don't want to rush straight to the message. You want to massage them a little bit. You want to be a little bit more sensitive to their emotions. So different types of personalities, you can communicate the same exact message. You can write down one sentence, for example, and give it to 10 different people. And I'm sure, and if we think about it, these are things that we don't necessarily tend to think about, but I'm sure if you did think about it, if you wrote down a sentence and gave it to 10 different people, their impression of the meaning behind that sentence could be very, very different. And that's not because the sentence is vague, and that's not because you're not necessarily making a point very clear in that sentence. It's because different people, the way their personalities, the way their brains operate, they perceive those messages and they perceive those words on those pages to have different meanings and to have an overall message that may be different from one another. So I'm going to pause for a second. Michelle, have any questions come in so far? Or am I just captivating everyone to the point where we're not getting anything in?
Right now, we do not have any questions. though I am curious to if there is a predominance within the DISC profiles. Do companies within certain um, industries tend to lead a certain way with a higher proportion of certain ones?
In my experience, it's less about industry and more about roles, quite frankly. Disc
Okay.
profiles tend to predict how people will perform in different roles. So, for example, I work with a lot of salespeople. Salespeople, the most successful ones, tend to be high I, high influence. Makes sense. Salespeople want to influence people's behavior, they want to influence people to buy. They tend to be social, they tend to be folks that don't necessarily focus too much on facts and figures, but more about relationships. So high I's tend to be great salespeople, for example. High C's, compliance, they tend to be great customer service type people, okay? They tend to be folks that are very good at following processes. They tend to be very informative. You can see it says don't be casual or informal with them. So they tend to provide information. They tend to be straightforward, but they also tend to have that emotional quotient, for example, to handle issues from a customer service standpoint. Dominance, high D individuals. And by the way, so it's not just that you're one of these four when you do a DISC profile, by the way. And I'm high D, high I. So you can see again, my highest is D and my second highest is I, for example. So there are dozens upon dozens of different profiles based on all four of these categories put together. So there's a whole spectrum of ways that individuals can go. But what we do tend to see, and I'll tell you at our organization, we don't do a DISC profile before we hire someone. We don't want that to necessarily influence a hiring decision. We do it after someone's hired. And in our organization, for example, everyone's DISC profile is posted outside their office or outside their cubicle. So when you do go up to that person, you can see what their profile is. And hopefully that'll help you understand, okay, how do I want to communicate with this individual? What is their personality profile like? Which is, I think, an interesting way of doing it. Certainly was not my idea. They've done that for a while, but it does tend to be interesting. And what you do tend to see when you walk around our office, for example, different departments, you tend to see that recurring personalities within those departments. So individuals naturally do tend to gravitate to those types of roles within an organization that match up with their personality profile. So it definitely is interesting. I'm certainly a fan, and just as a data junkie in general, having an access point of data in terms of quantifying someone's personality to an extent, it certainly is interesting to me. And I think it's something that we vastly underutilize, quite frankly. And we're going to talk as we continue about ways that we can benefit from collecting a data point such as a quantifiable metric of someone's personality, or at least a point on a spectrum, if you will, of where someone's personality fits. So now we want to talk about who we want to communicate with, right? We're talking about benefits. Well, we want to communicate with the employees. We want them to know their benefits. Yes, obviously, some of the strategies we're going to focus on are going to be around healthcare. So I know we have a smaller group. I don't know if folks know how to raise their hands or not. If you check, and I'm just going to, we'll give this a test, and if it doesn't work, it doesn't work. But if you self-fund your health plan, can you click the raise hand option? And so we see a couple folks. Oh, good, it's working. Good. This is a good way to interact. If you're fully insured on your health plan, can you raise your hand? All right. If you don't know how to raise your hand, can you not raise your hand? I think that's most of us. So, the concepts, it doesn't really matter, quite frankly, if you're self-insured or fully insured, because at the end of the day, regardless of how your health insurance is funded, what the mechanism is, claims are claims, and claims drive expense, right? If you self-fund, claims drive your expense on an immediate level, because that's what you see right out of the gate in terms of your week-to-week or month-to-month expenditures. If you're fully insured, claims drive your expense when you get your renewal and your carrier says your claims experience is terrible, so we're giving you a 15% increase. Regardless, claims drive expense. So one great way to manage expense is to manage claims. And one great way to manage claims is to use data to understand what's going on within your plan that is driving claims activity, understand where those touch points that we can actually intervene and possibly either redirect care or prevent circumstances from becoming worse and more expensive. So understanding who we want to communicate with within our benefits plan in terms of what types of conditions or what types of issues are going on. We're going to dive much deeper into that. But also, even let's say we identify, for example, Scott is someone I want to communicate within the health plan. Scott is doing something that's either inefficient or costly, or there's something Scott could be doing that will hit those three goals, right? It's going to save us money, save Scott money, and get Scott a better outcome. So we want to communicate with Scott. That doesn't necessarily mean you want to communicate with Scott. In my household, for example, my wife is the one who makes all the doctor's appointments. I'm terrible at making doctor's appointments. I always put it off. You'd figure working in this industry, I would be gung-ho about taking care of myself and making sure I'm doing all the things I need to be doing. But guess what? I just don't do it. I'm a high D, high I, and so I guess my ego gets in my way of making doctor's appointments. So my wife tends to do that. She tends to take the mantle, if you will, on making sure I'm doing those types of things. So if we're identifying that, hey, Scott has an issue and we want to communicate with Scott, maybe we actually want to make a communication strategy geared towards Scott's wife. According to the Department of Labor, I found this very interesting. Women make 80% of the decisions in the home. So apparently my circumstance is not unique in the home. We also want to look, again, we were talking about it, stratifying your population into subgroups. So not only do we want to communicate with decision makers, we want to communicate with different groups and different populations, and then that's going to impact, again, who we communicate with, how we communicate with them, what we want to communicate. So we have to stop looking at our population as just one large group. There are different ways we can slice and dice our populations into smaller subgroups, and that's going to inform us in terms of what we're communicating, why we're communicating, how we're communicating. So again, we're thinking about all those questions as we look through each one of these touch points and bullet points. So let's give an example of population stratification. Within your population, I'm sure within your health plan, someone at some point has had a conversation with you about diabetes within your health plan. Diabetes is a large driver of direct costs within many health plans, and it's also a large driver of indirect costs within your health plan. What I mean by the indirect cost is that more often than not, someone who has type 2 diabetes, for example, has something else, right? We don't just have type 2 diabetes and that's our only health issue. A lot of people with type 2 diabetes have high blood pressure or high cholesterol or coronary artery disease or some other comorbidity that is accompanying their diabetes. So the claims and the issues that we see arise out of those secondary conditions, those would be our indirect costs, along with the direct costs, which are the costs for the diabetic medications, the test strips, the doctor visits, and so on and so forth, specifically as a direct result of diabetes. So diabetes, a tremendous issue within our entire population across the country, and certainly is likely somewhat of an issue at some level within your health plan and within your population there. So if we're going to have a conversation, we say we need to develop a strategy around diabetes management. Are we just going to communicate with every single individual that has diabetes? We certainly can, and there's certainly instances where you probably would. But what we also want to do is really, again, it's a lot easier, and I think we would all agree with this, it's a lot easier to communicate with smaller groups of individuals. It's certainly a lot easier to measure and make sure that message is getting through. It's certainly a lot easier to analyze and evaluate what those individuals are doing. You know, if I were to blast a message out to 1,000 people, it'd be very difficult for me to follow up with those 1,000 people to make sure they got the message, make sure they understood it, as opposed to if I sent a message to 5 people, certainly following up with those 5 individuals is a lot easier. And it's a lot easier to actually see and measure, are those 5 people doing anything differently because of that messaging, right? So within a population, for example, of diabetics, rather than blasting out of communications around A1C testing, for example, to the entire population, within your health plan, you might be able to get your hands on data that gets granular enough. So here's an example of diabetics. We're looking at claims data and seeing, okay, of our folks who have a diabetes diagnosis, who have not actually had an A1C test in the last 12 months. So even though we might have 6,000 diabetics within this population, this is obviously a very large population, only 849 of those have not actually had an A1C test in the last 12 months. So I've whittled down 85% roughly of the population and saying, I don't need to communicate about A1C testing with these folks because they're up to date, they're fine, they're doing what they need to do. So let's focus on this much smaller subgroup. Let's develop our communication strategy around these 850 people, as opposed to blasting a message to all 6,000. So again, getting very, very strategic around looking at as specific a group as possible and shrinking down our populations as small as possible. So we can be, again, very, very focused on our message. which makes it easier to get very specific in the actual content of the message and very easy to track the impact of that message within that population. By the way, I know this sounds like a lot of work. I'm also going to be sharing as we go through this why you're not going to have to be the ones that do this work. There's infrastructure in place where you can work with partners and vendors who handle all of this for you. This is more about making sure you're aware that these strategies and these concepts are already out there in the marketplace, and they are already out there for you to take advantage of. So here's another great example. This was from a survey. If you follow up with myself or Michelle afterwards, I'd be happy to share the complete survey with you. It was a survey that our organization conducted a year ago in the spring, actually, of 2019. And it was all around how individuals make decisions around their healthcare. And there was a wide array of areas that we questioned individuals when it came to their healthcare in terms of getting checkups, getting lab work done, getting surgery, getting their prescriptions filled, looking at different demographics, different populations, different coverage. You know, do you have your insurance with your employer versus a government plan versus uninsured, and so on and so forth. One of the interesting ways that we sliced the data was asking a question of whether or not you as an individual have a doctor that you would consider to be your doctor. We didn't actually ask them, I know this bullet says primary care, we didn't ask them, do you have a primary care physician? We just said, do you have a doctor who you would call your doctor? And half the people said yes, and half the people said no. This was tens of thousands of people responding to this survey. And so it was interesting that only about half the population self-reported having a relationship, a good relationship with any sort of doctor, and half said they really didn't have any sort of relationship with their doctor. But when it came to cutting up the data by the response to that question, the results were, quite frankly, astounding. We asked them, how much influence do you feel over the following and the decisions that are made regarding the following? So how much influence, for example, do you feel that you have on your overall health? Those that also answered the question with having a doctor saying yes, 100% of them felt like they had moderate or a lot of influence on their overall health. Those that said they didn't have a doctor, 40% said they feel like they have no influence on their overall health. It was certainly interesting. A chronic condition, again, 100% felt that they had influence. 78% said they had a lot of influence over a chronic condition that they were diagnosed with when they have a doctor. Only 21%. Look at this one below it. How much influence do you feel over having a surgery? 65% felt that they had a lot of influence over whether or not they needed to have a surgery. Those that said they didn't have a doctor, none of them felt like they had a lot of influence. And by the way, this was more than 2 people in this bucket. There were hundreds and hundreds of people in this bucket. Taking medication. I mean, just look at the differences here. So what we have identified here is significant importance, or at least correlation. Now, I strongly caution you to jumping too far to a conclusion, because there certainly is a concept of selective bias here, which in terms of maybe these people that say they have a doctor are generally more engaged with their health. So because of that, they're going to feel like they have a lot more influence, where those that are not engaged with a physician are also not engaged in their health. So that's why they tend to feel this way. So there may not necessarily be a direct, you have a doctor, therefore you have more control, or feel like you have more control. There could be more of a correlation. You have a doctor because you feel like you have more control. So correlation and causation, a little bit different here, but there certainly is a correlation here. And it's certainly not a stretch to think that if we can encourage people to become more engaged, and certainly one of the easiest steps to take becoming engaged in your own health is developing a relationship with a physician, there's certainly no reason to believe that getting people from this bucket here into this bucket will have a positive impact. So just this question alone could be a very, very significant question within your health plans, for example, on understanding 2 very distinct populations when it comes to how engaged they are in their health and how engaged they are in making decisions. So we, for example, I'm sure many of you utilize some sort of benefits administration system where you do online open enrollments and things like that. That is a great opportunity to gather data. You don't just have to ask questions about what health plan do you want, what dental plan do you want, what do you want to do with your FSA. You can ask other questions. So for example, you can ask the question, do you have a doctor that you would consider to be your doctor? And by getting answers to that questions in and of itself, you can figure out who in your population is really engaged in their health and who is not engaged in their health. And that can help impact your communication strategy, because the message that you send to these folks here will be vastly different than the message that you send to these folks on the left, just as an example. I'm going to pause, actually. Anything pop up, Michelle?
Right now we haven't, but this is very, very interesting. And especially the correlation between the primary care doctor and the correlation of control over health. With that though, in the resurgence of telehealth, are you guys, and I don't even know if we've tracked this yet, but is there an opportunity to track the impact of telehealth on that relationship element?
I would say certainly. I think that the data that we get specifically from self-funded plans, the data that we can get from fully insured plans certainly is not as robust, unfortunately. A lot of that is protected by the carrier. It's one of the reasons why as an organization in general, we like to promote self-funding, assuming that it can work for a population. But we certainly gather, for example, those telehealth encounters as a data point. So we can stratify a population based on telehealth engagement. And there are other strategies that we're using telehealth to start to kind of take from an embryonic stage to a more developed stage. So things like direct primary care or even technology-based primary care. There are companies out there that are basically leveraging telehealth to the point where you are utilizing telehealth, but you're having that interaction with the same provider over and over, and you're forging that primary care type relationship via the telehealth system as opposed to necessarily having to always be going to that doctor in person. So even though I might live in Miami, my primary care physician could be in Chicago, and that's fine because I can still go to Quest and get all my lab work done. I can still get all of my tests done. They can still instantaneously be sent to that doctor in Chicago who's my direct primary care via telemedicine. So the resurgence and the growth in telehealth in a COVID environment, I think, has really expanded the opportunity to get people more engaged, because certainly one of the driving factors for people not to be engaged with a physician is the fact that they simply, and I'm not sure honestly if it's in this presentation, it's in the study. That was one of the questions we would obviously ask is, if you're not engaged with a physician, why not? And a lot of it is around trust. They can't find a physician that they trust. A lot of it is just around apathy. You know, I don't want to get off my butt and go find a doctor that I like. So technology is a way to help close some of those gaps and solve some of those problems. So I think leveraging some of those strategies could be huge in improving some of the circumstances, especially those that say they don't have a doctor.
Okay, thank you.
Sure. So let's move on and think about when we want to be communicating with our members. Typically, again, the vast majority of our communication occurs around open enrollment, just the way things are, right? We're communicating about the benefit options, we're communicating about plan designs, we're communicating required notices, and then we tend to kind of go dark, if you will, for a while in terms of communicating with our members. So again, these are things that we should be considering. So one example, again, high cost event, high cost acute, usually a single event, is surgery. So again, I'm sure many of you can look back within your plans and think of when a member had a surgery and it was extremely expensive. And surgery doesn't always have to be extremely expensive. I'm going to show you that coming up in a second as well. So notice, we asked the question, have you ever had surgery, for example? Those that have a doctor and don't have a doctor. Very, very, very similar answers. About 8 out of 10 people that we surveyed, which I was shocked in and of itself, it was so high, have said they've had some sort of surgery. Now, some people might think getting an ingrown nail removed is surgery, and it is. So there's certainly a range of options in terms of what we would consider to be surgery, from a fingernail to a quadruple bypass. But what was interesting is the overall preponderance of the response was basically the same, regardless of their doctor relationship, if you will. But again, notice the behavior differences. You would think that those who have a doctor would be much more trusting of that first doctor and follow through with what that doctor said. So 70% of the time, someone who said that they were aligned with a doctor had that recommendation and took that recommendation to have surgery. Only 22% of the time did an individual seek a second opinion. And you could see 78% took that first opinion for where, 80% when. Interestingly enough, those that had a doctor, they were much more selective necessarily about which surgeon they actually used when it came to that surgery. Notice those that didn't have a doctor. Those that don't have a strong physician relationship, it's very ironic to me because trust was still the number one reason why people say they don't have a doctor. And yet at the same time, nearly 100% of the time across the board, whenever a doctor told them they need surgery, They got the surgery, they went where the doctor said, they used the surgeon the doctor wanted to use, and they had the surgery when the doctor said to have the surgery. So they completely trusted and went through each and every step. Regardless of which bucket you fall into, though, I do want you to realize whenever a doctor says you need surgery, that first doctor has tremendous influence over whether or not you're going to have surgery, where you're going to have surgery, and when you're going to have surgery. Even with your engaged population, we're talking nearly 80% of the time, they're still going to end up doing pretty much exactly what that first doctor says. And nearly 100% of the time, the other population will do what that doctor says. So if we want to impact how folks go about procuring their surgery and viewing their surgery, we need to communicate to them either exactly when or ideally even before their doctor tells them to need surgery. How can we communicate to members before their doctor tells them to need surgery about their options for surgery? That seems nonsensical, right? How will we know before a doctor knows that someone needs surgery? So again, even those that sought a second opinion, this just hammers home the point that even getting a second or a third opinion, it doesn't really change what people do. They do what that first doctor says. So surgery, why is this important? Well, here's an example from total knee replacements. And this is from November and December of 2018, and a couple actually happened in January of 19. So just pointing out, this is a very, very, very narrow time frame, just mining our data for total knee replacements. Total knee replacements all stayed in the hospital between 1 and 3 days. And these are all different hospitals and different events. So I highlighted some in green and some in red to show you the differentials in terms of the cost of a knee replacement. You have employees that if they need a knee replacement or their family members need a knee replacement, it could cost $19,000, $20,000, $21,000, or it could cost $60,000, $61,000, or even $70,000 for a knee replacement. So you're talking about a cost spread of greater than 3 to 1 for the same exact procedure. What I can also tell you is, and I hid the hospital names, this is really it's not meant to bash any individual hospitals. It's to show you that the cost of healthcare, there is no uniformity. These are all in-network providers within a health plan. It's not like all the hospitals are getting paid the same amount by the insurance carriers. Each hospital negotiates their own deal. I can assure you, through our analysis of data, that cost and quality have absolutely no relationship in healthcare. If anything, it's geared opposite of what you might think, which is the more expensive providers for many of these procedures do tend to shade to actually having worse outcomes than the lower cost providers. And part of that, when you think about it, makes sense because the hospitals that do the same thing over and over again, the orthopedic specialist hospitals that have turned knee replacement into really borderline an assembly line type procedure, they do it so well, they've gotten so good at it, they've developed such a process, they can keep costs down and really have superior outcomes. Where the ones that charge more, it's because they don't necessarily have all the equipment. These are more one-off type events and they have to charge more to maintain their level of profitability. But I have my $2,000 deductible 90% plan. Remember what we were talking about at the beginning. What do I care if it's $10,000, $20,000, $50,000? I'm paying my $2,000 deductible on my co-insurance. I'm hitting my max and I'm done for the day. So what does it matter where I go? Obviously, we'd want to communicate to members, hey, if you need surgery, here are some of the top providers that we recommend. Here's where you should go, or here's where you should consider if you need a knee surgery. But as we saw, we want to make that communication before they're told they need a knee surgery, because if their doctor says, hey, you need a knee surgery, go to hospital 47, and that doctor's recommending it because the surgeon at hospital 47 is her golfing buddy. So we want them to go to hospital 32, right? How do we get that communication in the hands of someone before they need surgery? That's where data comes in again. We're using data to drive impactful communications. So within your data, and I'll talk about the data that we get, for example, within a self-funded plan, we can see the types of diagnosis individuals have already had. We can see the types of procedures individuals have already had. So for example, what I'm showing you here is a query for a population, and we're looking for folks that have had osteoarthritis already diagnosed. We're looking for folks that have already had a drain or an injection into a joint, but they've not had a knee or a hip replacement yet. So these are folks that have osteoarthritis, they're already getting some sort of injection or they're already getting fluid drained from their joints, but they actually haven't had surgery yet. So this is a great opportunity to say this population is the population that is most likely going to be told they need a knee replacement or a hip replacement at some point. Let's hammer away at this population and communicate to them where they might want to consider if they need a surgical event. Just again, using data to figure out a strategic time as to when we want to communicate to them. So now we're thinking about all of these factors, right? We're thinking about how do we want to communicate? Text message, mail, phone calls. Who do we want to communicate to? Which types of populations and cohorts are we looking to communicate to? And who in their household? When do we want to communicate to them? So now we actually have to craft our message, right? We need to identify what the problem is, why the problem exists. We're going to find the who, how, and when to communicate. But the communication really needs to focus on why, not what. So I'll give you some examples. So let's talk about, for example, folks that are not taking their medications. Again, we can utilize data. We can see people have all these types of conditions that you see here, and we could see who hasn't filled a prescription for their medication for these conditions in any given time frame, right? So here's an example. Members that have heart conditions that aren't taking their medications. So that's the what. That's the what of the problem, okay? We're identifying we have members that are not taking their medications, and I can assure you, and I'm sure it wouldn't be a shock to you, people with serious health conditions that don't take their medications are much more likely to manifest in an acute event and an expensive event. So it's going to cost the plan money, it's going to cost the member money, and they're going to have a poor outcome, the exact antithesis of what we're trying to achieve when people don't take their medications. So obviously, we want to encourage and help these people take their medications, okay? So the non-data-driven approach, the non-impactful approach would be sending out a communication to the entire population, telling people, take your medicines as prescribed. And we're going to mail it out in a letter, or we're going to send an email to the entire population saying, hey, if you are on medications, take your medication as prescribed. Because all we're doing there is we're communicating the what of the problem, which is people are not taking their medications. Now remember, we want to communicate the why, not the what. So the outcome of a strategy like that, I'm sure you'll have people who will perceive that as a big brother. What are they talking about? Is this message for me? Most people probably will just ignore it entirely. It will not speak to them in any way, shape, or form, because the message itself is not something that they're really concerned about. I can assure you most people that don't take their medications are very aware of the fact that they're not taking their medications, and a message from their employer telling them to take their medications is not necessarily going to change that behavior. I had a mentor, on the sidebar for a second, I had a mentor, and they had a saying which I thought was absolutely fantastic, which was, people only change their behaviors through inspiration or desperation. Inspiration could be something like, my wife lost a ton of weight. I can see how happy she is. I can see how great her life is. I want to do that. That's inspiring to me. That's inspiration. Desperation, my doctor says I had a mild heart attack. I need to lose 50 pounds or I could die during the next one. Now that's desperation. I can assure you, a letter telling me to take my medication from my employer will provide neither inspiration nor desperation. So it's not likely to change my behavior. Even things like incentives and payroll deductions and things like that. The data is very, very, very sparse on having significant impacts, even through things like payroll deductions, and using that as a tool to drive behavior. Because again, it does not create that inspiration or that desperation. So let's get back to this medication example. So again, we're going to go back to that survey. We're going to use the data to understand why this problem exists. And so we want to understand why people may not be taking their medications. Well, first of all, again, we have these two cohorts, the ones that have a doctor and the ones that don't have a doctor. So understanding within my population which bucket these people fall into will, again, help me understand the why. Let's focus on the folks that don't have and are not engaged with a physician. Number one reason people say they don't take their medication, 45%, they simply forget. I'm very forgetful. I forget to take my medication. I forget to get my prescription filled. 38 said, I feel fine. I don't need to take it. I feel fine. 34%, I'm depressed. I'm not motivated to take it. By the way, really, really shocking. Again, a little bit of a sidebar here. The most or the least given reason people said for not getting their prescriptions filled and taking their medications, cost. I think a lot of us would have presumed that people don't get their medications and they've got the prescriptions because it's too expensive. But ironically enough, that was the least given reason. So now we're getting an understanding, okay, within this population with people that aren't taking their medication, they're not engaged with a physician. They say they forget, they don't think they need to take it, they're not motivated to take it. So there's a high level, we can really chalk a lot of this up to apathy, quite frankly. So now we're understanding, okay, these people are not engaged with their health, they're not engaged with a physician, and they're kind of apathetic about their circumstance. So a data-driven approach, for example, for communicating with this particular individual, again, would be to be very, very focused. So let's say, for example, again, at open enrollment, we've asked the question, do you have a physician? Maybe we ask the question at open enrollment, who in your household makes healthcare decisions? Maybe we ask the question, how would you like to receive communications regarding your health plan? So maybe in this world, if it's the spouse of a baby boomer that says they have a primary care physician, okay, we would send a mailing because the baby boomer says they like to get things in the mail. And those that said they have a doctor, makes me feel bad, I haven't improved. These are the likely reasons, or I'm worried about side effects. These are the reasons people that are aligned with physicians tend to say they don't take their medications. So let's send a personalized mailing to the spouse saying, if so-and-so is on X drug, here are a few other drugs that they can talk to their physician about, which may make them feel better, may limit their side effects, and may actually be more effective and provide them a better long-term result. Maybe that's a conversation that you should be having, or your spouse should be having, with their primary care physician. Now we're addressing the why, not just the fact that they're not taking their medications. Maybe we have millennials who don't have PCPs, and the data does tend to show that a lot of the folks that are not aligned, believe it or not, are millennials. They don't have physician relationships. They like to receive a text message. Maybe we should remind them that the dosing specifications are very, very specific on taking the drugs. And if they don't follow through with their treatment, even though they feel fine right now, here's some of the potential outcomes. And maybe to help them along, we're going to give them an app that can help send them reminders and gamify the experience for them to get them more engaged. So same issue, totally different responses based on the individuals and based on the data that we're now gathering based on those individuals. So I told you I'd mention who has time to do all of this. This sounds like a lot of work. Personalized message for every single one of my employees for every single one of their issues. It's not something that we can really focus on. First and foremost, again, if the ultimate goal at the end of the day is, obviously we want higher value perception, but really what we're really also focused on is lowering our costs, right? We want to make our renewals much more stable. And if we're self-insured, we just want to keep our costs down. So what you're looking at here is a distribution list of both population and expense. So what I mean by that, let's think of a population that has 1,000 people in it. In that 1,000-person population, 1%, so 10 people will account for 31.7% of a health plan and pharmacy plan's claim spend. 10 people accounting for nearly a third of the spend. The next 4%, so now 40 more people, so we're talking about in combination here, 50 people in that 1,000-person population are going to be driving nearly 2/3 of all the claim spend. Pretty profound, actually, when you think about it. 1,000 people, 50 of them are going to account for 2/3 of all the claims dollars. I also find this interesting. This data is a little old. The numbers have changed, and I'll give you some insight into where they're at now. Add these two bottom ones together, the bottom 70% account for 5.8% of the spend. Right now, it's actually under 5%. 70%, 700 people on that plan account for less than 5% of all claims dollars. So when we're talking about communication, first of all, again, we want to narrow it down. Identifying these current high claimants and future high claimants, those are the folks that we want to be communicating with. So let's really pare it down and focus on that low-hanging fruit. There's technology out there, whether it's through your benefits administration system, whether it's through other partner vendors and different disease type vendors, whether it's through your broker or consultant or through your health plan. All of these different avenues have the ability to do these types of things. And if they say they can't, then maybe it's time to evaluate which carrier you're working with. Because if one carrier says, no, we can't do that type of communication, maybe it's time to look at another carrier. We might give up a percentage point or two on the discounts, but if we can drive down claims within this population, we're going to save that money on the back end. If your benefits administration system or payroll system says they can't do those types of communications, maybe it's time to evaluate another system. Again, an incremental increase in costs for some of those systems may generate tremendous ROI if we can get these types of outcomes that we're looking for. And along those lines, and the last point I make before we'll stop and hopefully have time for a few questions if they crop up, is you have to measure outcomes. And you cannot rely necessarily on the vendor that you're choosing as the one to provide the outcomes. If I work with a diabetes management company and they come to me at a meeting and say, oh yeah, we're saving you $1 million a year. Here's our outcomes and here's what we're doing. I'd have to look at it and be very suspect, because why would they come to me and tell me anything other than how much money they're saving me? They certainly aren't going to come to me and say, no, none of this is working. Sorry. But here's our renewal fee for next year. So you have to measure your own outcomes, or again, work with your trusted advisors and have them measure the outcomes. You have to determine what metrics you're going to measure before you implement these programs. So for example, we're going to want to measure how these numbers change. How does our diabetic compliance, our medication adherence rates, how are these things changing? That might be a metric we want to measure. Measuring simply cost overall, not a good metric because there's so much variability there. So get very specific in terms of what you want to measure. Certainly using employee feedback, measuring satisfaction rates, measuring value perception. Those are another great indicators that you can use to measure the outcomes of these programs. But if I were to summarize the entire purpose here, you cannot continue to live in a world where your communication strategy is a one-size-fits-all strategy. There's so much information out there that you can take advantage of, that your advisors and partners can take advantage of, and you can commingle data from different sources and different data sets to really get highly effective in terms of using all the information at your fingertips to develop strategies that really address the underlying causes behind these issues. And that's what's going to get you the best outcomes. And that's what's going to get you the most ROI. And quite frankly, it's not going to cost you nearly as much time and nearly as much money as you think, because all of this information is out there already for you. The partners and vendors are already out there. And in some cases, they might even be already in place with you and you're not aware of it. But this is the way to take your communication strategy to the next step. Increase the value perception of your plan, save the plan money, save the member money, and drive better outcomes. So with that, we have about 5 minutes for questions. So Michelle, I'm hoping against hope that someone has asked a question at some point.
Actually, I have somebody messaged me over a question. So once again, want to remind people, if you do have any questions, please feel free to use the Q&A or the chat feature. The question that was posed was, is there a particular segment of the population or particular conditions where you may want to steer the group away from a telehealth option?
Is there a specific segment where you'd want to steer them away from a telehealth option? I think in general, what you're going to see with telehealth is, obviously telehealth is great from a diagnostic standpoint. It's not great from a treatment standpoint, right? A doctor cannot treat me via telehealth. So what I would say is we need to figure out the balance between the two. So for example, let me give a real over-the-top type example. Let's say I have rheumatoid arthritis or psoriatic arthritis. I'm sure many of you are familiar with drugs like Humira, Enbrel, Stelara, super duper expensive drugs. And other folks take drugs like Remicade, for example, and some folks that get those drugs, they actually have to go and get infusions done. Cost for infusions can vary profoundly. And when I say profoundly, we see some people getting Remicade infusions that cost $5,000 a month. We see others getting Remicade infusions, same exact drug, going to a different provider. Instead of $5,000 a month, it's $60,000 a month for the same exact thing, literally the same exact thing. It's just based on the provider and the deals that these providers have negotiated with the insurance carrier. Telehealth is not going to help us necessarily steer someone who's diagnosed with rheumatoid arthritis to a lower cost infusion provider or a lower cost facility. However, what there are out there, so I'll throw one vendor out there just because we've worked with them a lot recently and I think they're great, a company like HealthJoy. So what HealthJoy is a mobile-based technology. They integrate telehealth with things like care coordination and concierge service. So a program like that, for example, you can use the telehealth aspect, but then if it comes to the point where you need something more advanced from a treatment standpoint, then you can leverage the concierge programs and they can put in place protocols and strategies to drive people to the types of providers that you're looking at, to the point where, let's say, for example, you build your own network. There are lots of organizations that are building their own networks or direct contracting. Let's say you have a company and you have 1,000 employees all in one town. You can certainly negotiate with that hospital in that town and say, forget Blue Cross or Cigna or Aetna or any of those. we want to negotiate our own deal with you to send our members to you. We have 1,000 employees. Let's set up a relationship that's going to work for both of us. You can do things like that. And so you can use these technologies to drive that. So I think the high cost treatment type conditions, telehealth's not going to help you as much. But if it's from a diagnostic standpoint and your kind of day-to-day stuff, obviously telehealth is a great option there. So thank you for that question.
I do have another one that has come in, and this one is on the second opinion. In terms of second opinions, is there an age group that is less likely to get second opinions? And there's a follow-up question. Should they be recommending to get second opinions?
So ironically, when we did that survey, and like I said, if you want the survey, certainly reach out to me. My email's here. I'll shoot it over to you. Age was obviously a question that we asked for all the respondents. And so we broke up all the responses, just like we did for that doctor question. We broke up all the answers based on age. And there was no significant difference in response based on age. So it's not like older individuals in their 40s, 50s, 60s versus 20s and 30s, for example, were more or less likely to seek a second opinion. So in terms of that aspect, age was not necessarily a good predictor of someone's behavior when it came to second opinions. Now, that being said, we are really starting to dive into something called social determinants of health, which uses things like age, like income, like where you live to have a better understanding of different issues that may or may not be more applicable to you. But so the follow-up, should you be recommending second opinions? I would say if it's for a surgery, a major surgery especially, absolutely. The cost of a second opinion is minimal compared to the cost of getting a better outcome. I'll give two quick examples because I know we're short on time. One is joint replacement. So we developed a program at Assured Partners where we've directly contracted, as I mentioned, direct contracts with some leading hospitals in the orthopedic space. And basically any of our clients, their employees can go to those hospitals if they think they need orthopedic surgery or if they want a second opinion. And what we found over the past almost 2 years now is half the people who go to one of those leading providers who've been told you need knee surgery or you need hip surgery are told you don't need that surgery. So the cost of a $500 consult to save a $40,000 surgery, it's tremendous. And the reason they're told they don't need surgery is local hospitals make a ton of money doing surgeries. They can get it approved fairly easy by the insurance carrier. So that $60,000 check is really valuable to that local hospital. Where some of these leading orthopedic centers that make billions of dollars a year, they're more concerned about their national scoring and their quality ratings. So they're going to follow those evidence-based guidelines to the T. So if you don't check off every single box, they're not going to recommend you have a surgery. So things like that, real great example. Another one is cancer. If you get a cancer diagnosis, 1 out of 3 cancers are misdiagnosed. And following the wrong treatment protocol for the wrong cancer can yield terrible outcomes and extremely high costs. So something like cancer, you should absolutely be getting second opinions on. So I would say for major things like surgery and cancer and things along those lines, absolutely get a second opinion. I think it's absolutely the best practice. And you can structure your plan to cover the cost because, again, the ROI of getting these things right is profound. It's obscenely high. And that can be part of your communication strategy. Communicate to folks based on diagnosis. Tell them get a second opinion. Tell them the plan will pay for it. Give them options. And that could be your communication strategy. And hopefully that would create an impact.